a huge help in improving academics. So we'll move over to the next speaker. The next speaker is Dr. Justin Howlett, one of our senior colleagues here at University of Cape Town, who will be presenting on the high dose rate prostate brachytherapy. Thanks, Justin.
Thank you very much, Sam. Can you hear me okay and see the screen?
Yes, we can. Thanks a lot.
Super. And a welcome to Murray McKenzie. Thanks for joining us, one of the doyens in brachytherapy in South Africa. And I look forward to your comments and questions at the end of the talk. So my talk today is focused on high dose rate brachytherapy. And up until very recently, high dose rate brachytherapy in my mind was simply the brachytherapy we don't have available in South Africa. We have low dose rate available. And so that was kind of where my focus was. However, we are in the process of establishing a high dose rate brachytherapy unit at Groote, and this has been something of a brainchild of Dr. Dave Anderson, and it's been sort of submitted to management 2018. So then 4 or 5 years in the pipeline, and I don't know if you saw the advertisement that we'd hoped to report our first case, but unfortunately, although we've got the equipment, we've got the training, we've got the source, there's a renovation that has been taking place to the radiation bunker that just allowed a bit more smoothly accommodate high dose rate prostate brachytherapy, and that renovation is not yet complete. So unfortunately, I can't share experience of the first case, but we are dipping our toes in the waters of high dose rate brachytherapy, and I'd like to just discuss our kind of planning and preparation phase for our first case. So as you kind of maybe picked up already, the difference being is that one does not able to do high dose rate brachytherapy at any center. One does need to have a radiation bunker, and there's a lot of things I learned about what this requires. There's very thick walls, no cell phone reception can go through. This makes the anesthetists anxious. They want a Wi-Fi connection so they can call for help. It needs video cameras so that one can monitor the patient as well as all the vitals, because the team, once you place the sources, goes out sort of around the corner into a control room where then one administers the radiotherapy. So there's a few logistics involved in these bunkers, and getting wires and cables through these very thick walls is not always that easy. So a little bit of a snag in our setup process, but that's kind of where we are in our journey. So just to kind of get this misnomer out the way, sometimes one hears junior colleagues talking about low dose brachytherapy or high dose brachytherapy. That is incorrect. It is low dose rate and high dose rate brachytherapy. So low dose rates is defined as a dose rate of 0.4 to 2 grays an hour. Mostly in South Africa in particular, we're using iodine-125. Palladium and cesium isotopes can also be used for low dose rate brachytherapy. And this is permanently implanted seeds, which gives a dose over weeks and months. High dose rate brachytherapy is defined as more than 12 grays an hour. It generally goes a lot higher than that. It's a temporary implantation using iridium-192, and those are done through implants and needles that are then put in for a few minutes and then removed. So the main advantage of a high dose rate brachytherapy is that its dose rate can be 1,000 times higher than that achieved by a low dose rate, but the dose in grays is equivalent. So one of the theoretical radiobiological advantages of a high dose rate brachytherapy is one can give quite massive doses of hypofractionation. So we know that prostate cancer cells divide slowly. They're said to have a low alpha beta ratio, and slowly proliferating cells are very sensitive to increased dose per fraction. An HDR brachy can give those high doses per fraction up to 19 gray per fraction. However, most people would be doing maybe 13 gray per fraction, which is a very high dose, and one can do this because it is conformal. One of the other radiological or radiobiological advantages is that it's got a greater biologically effective dose, which is in theory considered more effective than low dose rate. The biologically effective dose is a measure of the biological dose delivered, and is dependent on the dose per fraction, so one can get bigger fractions, the total dose, and then in the particular tissue's alpha beta ratio. And for the enthusiast, there's the formula there of how one calculates a biologically effective dose, essentially dependent on the fraction as well as the tissue that you're giving the dose to. The second thing is that one can also give a greater total dose of radiotherapy. So one can see on the left-hand side, and this is data extracted from external beam, that if one drops below 72 gray, your biochemical failure rates increase. If you're really able to push the dose up high above 82 gray, your biochemical failure rates decrease. And I think this is for a number of reasons. I think certainly there's mounting evidence that if one gets good local control, even if one has high risk features, or even in the metastatic setting, one gets better outcomes. When you dose escalate to the prostate, we've got now level 1 evidence proving that biochemical control is better when one gets better escalation of dose to the prostate itself. And that is also related to distant metastases. So in summary, and I've heard this said before, when it comes to prostate radiotherapy, only 3 things matter. It's dose, dose, and dose. However, having said that, these theoretical advantages of HDR, we haven't necessarily seen that translate into clinical trials. We haven't got a prospective randomized trial comparing HDR and LDR brachytherapy. We do have some prospective and retrospective single institution series that show excellent and comparable outcomes between the two. We do have longer follow-up with low-dose rate brachytherapy, over 20-year data now. The HDR is a much newer technique. We've got lots of, well, many of the series are sitting at 6-7 year data. So it's hard to really compare apples with pears, but it does appear that it is at least equivalent in terms of oncological outcome. But there are those theoretical advantages. What about practical advantages? So it is cheap in the sense that one doesn't have to order the source per patient. One has an existing source. I'm not sure if you're aware that in your hospital right now, there's a radiation source which is active and busy decaying. So for certainly cervical cancer, brachytherapy, these are used, and the sources decay over 18 months to 2 years, and that source continually gives off radiation whether you use it or not. So in that sense, if one has an existing radiation source, if one has the ultrasound and the software is the only requirements, and so maybe some disposables, then it becomes something that one can do on a greater volume without incurring running costs. So the capital costs are definitely there, but in terms of the day-to-day running costs, it may well be cheaper than low-dose rate brachytherapy. I say in some centers it may be an outpatient procedure because we'll talk about it now. There are some that will do monotherapy, a single fraction, but most people will do 2 or 4 fractions. And so it does mean that one would potentially come in and out for the procedure. A lot of centers do 1 fraction and then 23 hours later, another fraction. So it becomes a day admission. I think that's for kind of funding reasons in other parts of the world, such as Europe. But essentially, it's not intensive in terms of hospital bed stay. In terms of radio protection, it has an advantage that there's no free live sources. One doesn't have the worry of, have we lost the seed, getting out the Geiger counter? Is it in the drapes? Is it in the patient? Is it in the MIC applicator? And there's no risk of source loss or migration, migrating to the lung if it gets into a vein, or ejaculating out a seed if it gets into the seminal vesicle. And one doesn't have the radio protection issues such as avoiding pregnant women, children, staff, using condoms, etc., that one does advise for low-dose rate brachytherapy. The other kind of practical advantage is one can implant the seminal vesicles with high-dose rate brachytherapy. The disadvantages, however, is it does require repeat implants, whereas low-dose rate is a once-off procedure, and that does create anesthesia demand and a resource. One does need a shielded room, as we discussed, for the treatment delivery, and then you kind of tied down to a single institution or a single source, which can't be moved. In terms of other disadvantages, or at least things to consider, are exclusion criteria, and the exclusion criteria are very similar to low-dose rate brachytherapy. So your same patient that would be eligible for the one would be eligible for the other. It's not going to mop up patients that are not candidates for low-dose rate brachy. Similarly, to low-dose rate brachy, volume is a relative contraindication, but the bigger glands are difficult to implant because one gets the pubic arch interference and increased side effects. The very small glands are also difficult to implant because one can get increased urethral toxicity. Other indications that are mentioned, or contraindications, should I say, is infiltration of the bladder neck. One can't give dose in that area without getting a bladder neck contracture. If they've got significant obstructive symptoms, poor flow rates, those aren't the patients for high-dose rate brachytherapy. If you've got pubic arch interference, which you can predict based on volume of the prostate, as well as often the height of the patient. So very sort of big framed people may not have a bigger pubic arch and be able to get it through it, and one can overcome that with hyperflexing the legs, as one does with low-dose rate brachytherapy. And I think that's probably one of the nice things, is that there's a lot of the skills from low-dose rate brachytherapy can be transferred to high-dose rate brachytherapy in terms of the implants and the tactics and techniques and overcoming intraoperative problems such as pubic arch interference. And this is one which I didn't come across for low-dose rate brachytherapy before, but it makes sense, is that if you've got a very narrow rectum prostate distance, let's say less than 5 millimeters, which I think would be unusual, but perhaps a very wasted patient, then one's going to have higher rectal toxicity. Yes, one can use space or gel, but that does have its own potential downsides and costs in terms of infection, and perhaps not always showing a clinically significant difference in rectal toxicity. But be aware, if one is doing a truss ultrasound and there's a very, very thin gap between the rectum and the prostate, those patients are at risk for higher rectal toxicity for any form of brachytherapy. And then the obvious ones, if the patient cannot tolerate lithotomy or anesthesia, or as a recent TURP, because as you know, prostate brachytherapy or radiation itself, what the tissue cannot heal well in the presence of radiation, and one is going to have increased side effects. In terms of indications for high-dose rate, up to sort of a stage T3B, any cancer that's not got metastases is a candidate, any Gleason score, and can be used in all risk groups. There are two real kind of types of HDR and their modes, and the one is kind of monotherapy, when one is just doing the HDR, and the other is when one's doing it as a boost to external beam. The HDR monotherapy's got low acute toxicity and high biochemical control rates, but its series are more limited, and we don't have mature data at the moment. And so these are the various schedules that are described. We're giving 34 gray and 4 fractions, 36 gray and 4 fractions. Probably the most common one that one would use is 26 gray and 2 fractions. And once again, it doesn't sound like a big dose, but the biologically effective dose is certainly equivalent to a full 145 gray LVR brachytherapy. So at the moment, sort of monotherapy has excellent results with the median follow-up of 6 to 7 year range, particularly in the lower risk groups. This is one of the most recent articles I've found on HDR brachytherapy, and it comes out of the UK national cohort, and they've really pushed the envelope and done single fraction 19 gray monotherapy. And they're reporting their 3-year data, and unsurprisingly, those in the low risk group are at 100% biochemical free survival, but in intermediate 86 and high risk 75%. And they kind of say that it's important to have ongoing surveillance of this cohort as the data matures. So as attractive as it is to do a single fraction HDR monotherapy, which would make it as convenient as LDR, even this study is saying at this point, cautiously, one would at least give 2 fractions if one were to do monotherapy. A single fraction at this stage may be risky. And I think also if one is starting out, you give a dose of 19 gray HDR and you get your needle in the wrong place, that could be problematic. So HDR has got a nice attractive option for a boost to the external beam. So indications for when one would use the brachytherapy boost, and it's often very much standard in a high-risk patient, but one needs to think about, is there significant risk of extracapsular or seminal vesicle involvement? And then one would give the conformal brachytherapy with the external boost. The sequencing is undefined. Some centers do the external beam first, followed by the HDR boost. Some people do the HDR boost followed by the external beam. The regimens can be around about 10 gray and 2 fractions, 5 to 7 gray and 3 fractions, or 4 to 6 gray and 4 fractions. But I think the newer kind of regimens are working down towards less fractions. We've got real-time planning, and we've got good software that can make it safer to deliver higher fractions or higher doses per fraction in the HDR setting. So how does it work? What is the procedure workflow? And for those that are familiar with brachytherapy, LDR, it's similar. First, one does image acquisition, put in the ultrasound. One can take 5mm slices, one can take 2.5mm slices, and one can even take a continuous slice, so almost like millimeter at a time with the software. So one can get a really nice image acquisition, the same kind of scenario as prostate brachytherapy, and then the oncologist would do the contouring, and the medical physicist would do the pre-planning, and then the urologist would put the sources in, and those are needles. And the differences is that the needles need to go in 4mm further than where your first source is going to be activated. So the tip of the needle doesn't carry any ability to deliver radiotherapy. So in fact, there's this concept that one has to over-insert the needle slightly. So you should, to get a good dose to the base, pretty much put the needle into the bladder tissue. So unsurprisingly, one of the differences is that there's a higher rate of hematuria following prostate brachytherapy, high dose rate. But having said that, and we'll discuss why, a lower rate of acute lower urinary tract symptoms. Then after one's got the sources in and the pre-plan, one can then do real-time adjustment, and this allows for greater forgiveness. So if you look on the right, these kind of potentially 8 little slots, the physicist can then accommodate for perhaps an error of implantation or a patient movement, or the prostate is now changed in size dramatically, or squished or elongated, in the sense that they can place a source or a gap or any point, along that needle. They can make that whole needle a source. They can put 4 sources, 6 sources, 2 sources, 1 sources, and they can also adjust the intensity of those sources. So one can give a really high dose peripherally, and then one can give the intensity of the sources on the ones closer to the urethra less. So there is more ability to kind of play with it. Once you drop a seed in brachytherapy, it is where it is. Where here, once the needles are in, one can then play with the radiation that each section of the needle, if that makes any sense, can give. So that is said to give us greater forgiveness. Then one does the plan evaluation, and then the whole team goes across into the control room and for about 10 minutes delivers the radiation. And one of the important things in our renovation is the anesthetists have insisted that we must have a coffee machine in the control room. And so that is one of the things that has to go in to make this project a success. And then the post-operative dosimetry. So as you may know, with low dose rate brachytherapy, one can do a CT day 1 or day 30 and see where the seeds are. But with high dose rate, one doesn't have seeds to follow, but there's in fact quite nice software which can then be used to still do the scan and check for any changes in the prostate, edema, swelling, size, and use that together with what was given to kind of give you a dosimetry electronically or digitally. So in terms of toxicity, what are the advantages of HDR in terms of toxicity? So if you look on the left, your classic kind of radiotherapy is just a box, and then that can then be upgraded to a 3D conformal radiotherapy. But the brachytherapy is probably one of the most conformal radiotherapies and is said to be even more conformal than stereotactic radiotherapy, because one can achieve a very tight dose compared to any modern radiotherapy. And that is why one can escalate the dose so well, safe as beyond what you could do with external beam. One might say 3D conformal is old-fashioned, and most linear accelerators allow for IMRT. And if you look at these dose clouds from IMRT, one is getting really nice dose to the prostate, but nonetheless, there's still a kind of dose cloud around the other tissues and organs at risk, whereas one looks at the dose cloud for HDR and probably LDR for that matter, and there's a very conformal dose cloud. So that is one of the reasons why one doesn't get significant, certainly rectal toxicity in comparison, bowel toxicity. And in fact, one gets less genitourinary toxicity with HDR. So because there's a higher dose rate, the LUTS resolves over several weeks. With low dose rate, the LUTS takes a few months to resolve. However, the late genitourinary toxicity, looking at, there was a study showing 7-8 years down the line, it was very similar to that of low dose rate brachytherapy. So it's just really the acute LUTS that is improved. As mentioned, there is more hematuria with a high dose rate because of the fact that you often are putting the needles in a little deeper. The other thing which is often not mentioned in radiology literature or confined to a very small section is external beam radiotherapy. All forms of radiotherapy put one at risk for a secondary malignancy. And that risk is decreased from 5 to 1% more or less if one gives brachytherapy compared to conventional external beam radiotherapy. And so one other advantage of giving more conformal radiotherapy. This is an interesting study from Juanita Crook and her team at the Canadian Center. And this is using a increased dose to the dominant intraprostatic lesion, comparing HDR and LDR monotherapy. And this is a phase 2 randomized controlled trial. One of the nice things about the HDR system is one can get a MRI ultrasound fusion done with the system, biopsy, should I say. And then once one's done the MRI fusion biopsy, one can then also kind of tell the computer which needles were positive, and then it can match the histology as well as the MRI with the prostate that you have in front of you. Then when you're doing your real-time planning, one can then see where this dominant nodule is. And if you, I guess, lucky, or you've got your fusion done well, your PIRADS 5 lesion will correlate with your Gleason 7, and one can then dose escalate to that dominant nodule. And this is obviously a little easier with LDR. one has to drop more seeds in that area or make that area hotter from the kind of physics side. But with HDR, one can really just turn up the heat on those needles that are going through the dominant nodule, and bearing in mind your dose constraints and your organs at risk, and then still give a dose to the rest of the prostate. I think is quite nice, because the concept of kind of single hemi-gland ablation or kind of focal therapy is still a little perhaps experimental, or a little bit only for clinical trials, where here you're not denying the rest of the prostate its dose. One is just escalating the dose to the dominant nodule and giving, the rest of the prostate a good dose. And this kind of, for me, gives the best of both, of having your focal therapy without having the risks of focal therapy, without treating what is a multifocal disease in prostate cancer. And this study, this phase 2 study, showed that the HDR brachy outperformed LDR when it came to dose escalation. So kind of in summary, the difference between the two techniques: LDR is permanent seeds, usually iodine 125, dose delivered over weeks and months, and the side effects, follow the same kind of half-life of 60 days, which is iodine 125. One has some radioprotection issues, although we've got protocols in place to manage that. The high dose rate's a temporary implant delivered in minutes, and the side effects resolve over weeks, and the radiation protection issues, once you're out the bunker, are not as important or worrisome. We've spoken about the biological advantages, although we haven't seen this borne out in clinical trials. One has more accurate and flexible dosimetry, as one can adjust the radiation to each part of each needle, rather than relying on a seed that goes in. One can get better coverage outside the capsule, including seminal vesicles, and one can dose escalate to a dominant nodule. And I think for us, perhaps maybe where this might have a role is that it is a cheap and sustainable option in the safe sector once you've got the equipment, because if you've got the oncologist and the urologist and you've got the source, one really just needs the anesthetist and some needles, and one can go through. So that's kind of the primer and introduction into HDR. I have focused a lot on the differences between that and LDR, just for the purposes of this talk, but there's a lot more we could go into, and I look forward to any comments and any questions.
Hi, Justin. Thanks a lot for the excellent talk and presentation, and for the efforts that you're doing in driving the brachytherapy program in Kuriskia. And certainly the low dose rate patients are very happy. We're waiting to hear how the high dose rate patients will feel. Just a quick one, there's a question on the charts there, but I just wanted to ask you, are there any differences in acute toxicities in low dose rate versus high dose rate? Because my understanding, you're delivering a very high dose, you're delivering the same thing, but dose, but at a shorter duration in the high dose rate. Are there any differences in acute toxicities or not?
Yeah, thanks, Sam. I think the main difference is the length of the lower urinary tract symptoms. So the patients have a shorter period of LUTS that resolves within a few weeks, versus the LDR patients, they have LUTS certainly probably peaking around 3 months. I think if one gets the implant okay, and one chooses the patient correctly, and one gives some alpha blocker, that isn't always necessarily an issue, but it's said to be acutely less genitourinary toxicity. The kind of downside to that, I think, is hematuria and needing a second kind of fraction, which can be done 24 hours later and on the same admission. But that does kind of create a little bit of logistical headache. But in terms of the and in the long-term side effects, genitourinary are similar. So it really is, I think, related to the short-term period.
Right, thanks, Justin. There's a question for you from Kitso on the chat.
Yes, thanks, Kitso. I did actually see that one can give HDR as a salvage. In my mind, it felt like perhaps a little bit of fine print, and certainly I didn't want to advocate giving salvage HDR after initial EBRT, but it is described. However, I don't think there's huge amount of data in the ESCO guidelines on HDR. It's really a couple of lines. So it is described, but I think salvage treatment for prostate cancer, salvage local treatment for prostate cancer is not got big data, whether you're going to do surgery, HIFU, brachytherapy, HDR, but certainly it's an option and something that one could explore if one had the experience, but I wouldn't advocate it at this point.
Do you have any further questions for Justin on the floor? Okay, there's another one now in the chat there, Justin.
Yes, so the same kind of criteria in terms of Qmax. If you've got a flow rate of less than 10, I would steer away from even the HDR brachy, and ideally you'd want it more than 15. So essentially the same exclusion criteria for LDR as for HDR. So it's really comes to what you feel about the radiobiological advantages and the practical advantages. And certainly, yeah, I think in the private sector, the LDR makes sense because you can do it anywhere, as long as you have the human resources and equipment and you can move it around. But as I said, in the government sector, you at Baragwanath, you've got a source sitting there. You've got at least sort of the software programming for the cervical cancer one, and one just has to then now purchase the prostate cancer module, as it were. Make sure you've got a good BK ultrasound machine, and then you're kind of good to go. And well done, Charlie, in setting up the LDR brachytherapy program at Baragwanath in the state sector. I think it's a great advance that, I certainly feel strongly that if you I've got a medical aid or not, you should have access to the best treatment, and it shouldn't be that we don't have the options to do the best for our patients. And so I think you'd be commended about getting those options available in the state sector.
Right. In the absence of further questions, I'd like to thank once again our brilliant speakers today, Professor John Lazarus and Dr. Justin Howlett, for excellent presentations. And we'll see you guys in the next week. Thank you.
Thanks, Sam.